Hello, everyone. Good morning, good afternoon, or good evening, depending on where you're connecting on. So welcome to this Global Thrombosis Seminar Series, animated by Invent. I'm Grégoire Legail. I'm a professor of medicine, and I'm a thrombosis physician at the University of Ottawa in Canada, and I'm the current chair of Invent. And the Invent-VT network is a partnership of 10 national VT research networks with more than 400 clinical investigators around thrombosis. And what we're trying to do is to support and promote collaboration between national networks to help produce high quality academic VT research. So here is a list of our current networks, which I'm sure most of you are members of. And thank you for all what we are achieving together. And hopefully more countries and more networks will join. And we've had very good discussions with potential new members. So that's exciting as well. So what's the seminar series? It's a new thing that we've been doing for the last year. And what we're trying to do is to feature some of these of the studies that the network supports, and at the same time trying to give a highlight or about some specific challenges that we're encountering as being academic researchers, or some specific method aspects, or anything that the investigators have acquired in terms of experience that they feel would be valuable for others to hear about. So it's really about our research and how to for the early career, or for the newer people or people who are new to international collaboration, how to make that even better. And a special thanks for Sanofi, who is sponsoring the seminar series through an unrestricted educational grant. Next. So today's presentation is a new exciting chapter. So it will be about the future of interventional cohort studies, and we'll hear from the RIVA-SVT study and how we can use that for future projects as well. So we'll have two speakers today, Dr. Walter Ageno from the University of Insubria in Italy, and Dr. Nicoletta Riva from the University of Malta in Malta. And so we will keep the question and answer for the end after the two presentations, but feel free to start putting your questions in the Q&A box, and we'll try to cover them at the end. So our first speaker today will be Walter Ageno. So as I said, he's a professor of medicine at the University of Insubria and the director of emergency medicine unit and of the thrombosis center of the Ospedale di Secolo of Varese in Italy. He has authored more than 600 articles indexed in Medline in the fields of venous and arterial thrombosis. He was the chairman of the Italian Society of Hemostasis and Thrombosis and of the scientific subcommittee board of the International Society of Thrombosis and Hemostasis. He's deputy editor for Thrombosis and Hemostasis, associate editor for the Journal of Thrombosis and Hemostasis, and Internal and Emergency Medicine. Walter, the floor is yours.
Thank you so much, Grégoire. Thank you for the introduction. I will start sharing the slides, hopefully. Should work. Can you see my slides? Okay, so thank you very much. It's a great pleasure for me to share the results of the RIVA-SVT 100 study, which was done in collaboration with the Invent network. So it's a great pleasure to share our results and many thoughts originated from this study. And of course, I'm doing that on behalf of the co-authors, and in particular, of course, Nicoletta, who's here today, and who ran the study with me. So these are my conflicts of interest. The study was partially supported by Bayer. So the management of patients with Splanchnic vein thrombosis is certainly a clinical challenge. This is an uncommon disease that's included in the list of unusual site thrombosis. And patients are quite heterogeneous, so this makes things even more complicated. The challenge originates, first of all, by the different underlying provoking factors that, as you can imagine, and as you know, will have an impact on what happens to these patients and on your therapeutic strategies. So we have patients with underlying liver cirrhosis, which can be, of course, a challenge per se, or patients with solid abdominal cancer with the hematologic malignancies, in particular myeloproliferative neoplasm, and many other factors that, of course, have an impact on our therapeutic decisions. Other sources of variation depend on the site of thrombosis. We can have a Budd-Chiari syndrome. We have patients with mesenteric vein thrombosis, and of course the outcomes are different according to the site of thrombosis. Patients with superior and inferior mesenteric vein thrombosis, there is a substantial risk of ball and infarction, and in patients with portal vein thrombosis, of course, we have to deal with other potential complications. To make it easier, it is being reported that almost a quarter of these patients may have GI bleeding, active GI bleeding at the time of diagnosis of splanchnic vein thrombosis or a recent episode, and indeed many others have major bleeding risk factors. But on the other hand, this makes treatment a challenge. On the other hand, we know that these clots need to be managed and treated because residual vein occlusion will lead to some very important complications, including, of course, and starting with portal hypertension. A number of studies have reported quite substantial long-term risk of both recurrence and bleeding. This risk varies based on underlying provoking factors. These are the results of a study that we carried out within the International Society of Thrombosis and Hemostasis and published now 7 years ago, just to show how different the risk, the annual risk of major bleeding and thrombosis can be among patients with underlying liver cirrhosis, or indeed those at the highest risk of both complications, patients with solid cancer, myeloproliferative neoplasm, and so on. So quite heterogeneous population, as we know. Indeed, anticoagulant treatment is effective, as supported by these meta-analyses and other studies. Unfortunately, we have to consider that these results are based on almost entirely on observational studies, which in most cases were retrospective by design. So there is, of course, a high risk of bias. But overall, pooling the results of these studies and comparing treated patients with untreated patients, it is quite clear that anticoagulant treatment substantially improves recanalization, which is a very important endpoint, especially for portal vein thrombosis, as you know, for all the long-term consequences that persistent occlusion of the portal vein may lead to. So significantly reduces the risk of progression in particular, and also possibly reduces the risk of major bleeding. So if this finding can be seen as quite strange in a way, and possibly influenced by, of course, the observational design of these studies. So there is a selection bias behind that. But there is also biologic plausibility for this finding, because if you do reduce portal hypertension, you will, in the long term, gain in safety, reducing the risk of long-term major bleeding. So I think this is important to consider. Now, in the studies that were included in that meta-analysis, almost all patients were treated with low molecular weight heparin and vitamin K antagonists. Some patients with unfractionated heparin, few patients with fondaparinux, but very few with the direct oral anticoagulants. Now, the direct oral anticoagulants are, of course, a very important possible alternative for the management of patients with splanchnic vein thrombosis. However, we have to be aware of the fact that their use is technically off-label because they were not included in phase 3 randomized clinical trials, as well as all other patients with the typical locations of thrombosis. On the other hand, most guidelines still suggest or recommend to the use of standard treatment when managing patients with thrombosis in a typical location. But most of all, no randomized controlled trials, especially the pivotal trials, have included these patients with splanchnic vein thrombosis or other unusual sites. Indeed, we are all aware of the fact that direct anticoagulants truly represent an important alternative because they are easier to use, they are more convenient for many reasons that we know, and of course they have been very strongly shown to be at least as effective, possibly safer than a standard of treatment in patients with usual site thrombosis. And we are substantially convinced by the fact that the evidence on the direct anticoagulants in patients with usual site thrombosis should be translated to unusual site VTE. But of course, we do have some concerns also for patients with the splanchnic vein thrombosis. For example, the reported increased risk of GI bleeding may represent a concern, since most bleeding events in patients with splanchnic vein thrombosis occur in the GI tract. However, there were a few guidance documents that have started to suggest the use of direct anticoagulants in patients with splanchnic vein thrombosis, such as those published by the Journal of Thrombosis and Hemostasis from the one of the scientific subcommittees of the ISTH, in particular for patients with non-cirrhotic splanchnic vein thrombosis. As you see in this guidance document, the use of DOACs was proposed as a first choice for initial management of patients without cancer and without cirrhosis. But also for patients with cancer, it was proposed as an alternative to long-acting heparin, of course, with great caution in patients with gastrointestinal cancer. In clinical practice, actually, many observational studies are reporting an increase in use of direct anticoagulants also in patients with splanchnic vein thrombosis. What we do have from these studies is quite reassuring. This is one of the largest reports published a couple of years ago from a single center in the United States of 330 patients with splanchnic vein thrombosis. 93 received direct oral anticoagulants. And if you look at the resolution of portal vein thrombosis, which again is a very important outcome, the proportion of patients with resolution was quite high in patients receiving direct oral anticoagulants, similar to what was observed with long-acting heparin, so good result in terms of efficacy. And also safety-wise, the results were encouraging, with the low incidence of major bleeding events in patients receiving direct oral anticoagulants. Of course, any comparison is influenced by selection bias, many other possibilities, but reassuring results. Unfortunately, this is an observational study, and many patients were studied on direct oral anticoagulants, not from the very beginning, not in the acute phase, but maybe after an initial course of other treatments, as it occurred in many other studies. So this is really the background behind the RIVA-SVT 100 study, where we wanted to assess the safety and efficacy of Rivaroxaban for the acute phase treatment of splanchnic vein thrombosis in the first 3 months, which of course represent the period at highest risk of both bleeding and recurrence. This was a single-arm prospective interventional study, so no control group in this study. And since we didn't have sufficient information to formally define the sample size, we started with this pilot study with this sample population of convenience of 100 patients. We focused on patients with splanchnic vein thrombosis that was not associated with cirrhosis. So patients with symptomatic, objectively diagnosed portal vein thrombosis, mesenteric vein thrombosis, splenic vein thrombosis were eligible if they didn't have known liver cirrhosis. We also excluded Budd-Chiari syndrome, which is a much more uncommon disease and with different features. So we focused on the most common sites of thrombosis. We also had other exclusion criteria, which for some, at least some of them are common to other studies. For a very practical reason, we decided to allow up to 7 days of parenteral treatment or other treatment of splanchnic vein thrombosis before the enrollment in the study. So, as you know, the window in the phase 3 clinical trials that led to the registration of the DOACs was 48 hours, but we consider more practical, more pragmatic to allow a longer period, which in clinical practice is not uncommon. So the treatment was as usual, 50 milligrams twice daily for the first 3 weeks, and then 20 milligrams once daily up to 3 months, where we measure our outcomes. The primary outcome was major bleeding, and the secondary outcomes included mortality, both overall mortality and SVT-related mortality, clinically relevant no major bleeding, recurrent splanchnic vein thrombosis or symptomatic VT in other sites, mesenteric infarction, increase in the levels of ALT transaminases, and vessel recanalization was another outcome, given the importance of this outcome. So overall, we enrolled 103 patients. It took us a lot to complete enrollment for several reasons. Certainly one was COVID in the end, but the study was certainly slow, as all these studies are. An interventional study in patients with splanchnic vein thrombosis is extremely complicated. These patients are uncommon, and it's not uncommon to see them probably too late to include them in an interventional study. And this is probably the reason why there are so few interventional studies in this setting. So it took us a while, but we were patient, and I think it was worth the time we waited to complete the study. And of course, thanks to all participating centers, in total 18 centers internationally. And I will have a list at the end of my presentation. 3 patients were excluded because of exclusion criteria that were present: portal cavernoma diagnosis, Budd-Chiari syndrome, and increased transaminases. So we analyzed 100 patients. 3 patients were lost to follow-up, and so we included 97 patients in the analysis of safety and efficacy, although we retrieved information on the mortality, dead alive status of the 3 patients, so we have full information on this outcome. And then we also had an additional 3-month follow-up. Of course, in these 3 months, and the investigators and the treating physicians were free to prescribe any treatment to these patients, but we wanted to see what happens at 6 months as well. These are the baseline characteristics of the patients. We have this mean age of 54, majority had portal vein thrombosis, as you expect, but more important, half of the patients had multiple site thrombosis. This means that the disease was quite aggressive. In terms of underlying factors, 43%, 43 patients had unprovoked splanchnic vein thrombosis. Inflammation or infection was present in 26. 9 had solid cancer, solid abdominal cancer. 9 had overt myeloproliferative neoplasm. 13 of 50 tested patients, so 26%, were JAK2 positive, so not all with overt MPN. And see, this is the breakdown of risk factors. In 21 patients, Rivaroxaban was the only anticoagulant drug, so they were enrolled before any other treatment was started. In all other cases, patients were enrolled after an initial course of treatment, and the median duration was 5 days. most patients received low molecular weight heparin. At 3-month follow-up, 90 patients were still on Rivaroxaban 20 milligrams once daily. So these are the outcomes. Major bleeding occurred in 2 patients. Mortality, 1 patient died. 3 patients had clinically relevant no major bleeding, and 2 patients had recurrence of splanchnic vein thrombosis. And these are actually the results that we expected based on evidence from previous studies on patients receiving anticoagulant treatment. But in details, I think it's important to see which patients had major bleeding. First of all, no patient had serious major bleeding. In both cases, we had, as expected, GI bleeding, which was adjudicated as major because of drop in hemoglobin levels. 1 patient had esophageal carcinoma, and 1 patient had a severe esophagitis as predisposing factor for bleeding. 2 patients who had thrombosis, 1 had underlying carcinoma of the biliary tract, and the other one previously had an unprovoked event. As regards recanalization, we have information on 91 patients who underwent imaging test after a median 99 days. Overall, more than 70% of patients had some recanalization, so very good result in this sense. A complete recanalization was adjudicated in nearly half of the patients. So I think this speaks very well in favor of this treatment from the beginning. Of course, there are limitations that need to be acknowledged. Of course, first of all, the single arm design of the study. But again, we will discuss later with Nicoletta about this type of design for these unusual diseases. Enrollment was low. We excluded 80% of the screened population. Main reasons for exclusion were absolutely treatment more than 7 days, and this speaks in favor of our decision to be a little bit more pragmatic. Other exclusion, very common exclusion criterion, were cirrhosis, which is a very common risk factor for splanchnic vein thrombosis, and the others are reported here. So my conclusions, dear colleagues, this was the first interventional study on the safety and efficacy of a direct oral anticoagulant in the acute phase treatment of splanchnic vein thrombosis. So this is something to be considered. Event rates definitely well compared with those reported with the standard of treatment, heparin and vitamin K antagonists. The rates of thrombosis improvement were high at 3 months, which is very encouraging and quite I would say, consistent with similar results found in patients with usual site thrombosis, the very favorable effect of the direct oral anticoagulants in this setting. Major bleeding events, as expected, occurred in the GI tract and certainly in patients with underlying severe gastrointestinal diseases. Thank you for your attention.
Thank you, Walter. So once again, we'll take the questions at the end. I see that some have started to write them down in the chat, so we can discuss that later. So our second speaker today is Dr. Nicoletta Riva, and obviously my my document where I had your bio has just disappeared on me. I will try to find it again. There you go. So Dr. Nicoletta Riva is a lecturer in the Department of Pathology in the Faculty of Medicine and Surgery at the University of Malta in Malta. She has special interest in unusual site venous thromboembolism, in particular splanchnic vein thrombosis. She contributed to the monitoring of several studies on this topic, such as RIVA-SVT 100. She's currently leading an international registry on the use of direct oral anticoagulant for the treatment of unusual site venous thromboembolism, the DUST study. Thank you, Nicoletta.
Thank you, Dr. De Gaulle, for the invitation and for the introduction. I'm going to share my screen. Okay. So basically, I will be talking about the future of interventional cohort study with regards to the treatment of splanchnic vein thrombosis with the DOACs. I have divided my presentation into two parts. So at the very beginning, I will go briefly beyond the result of the RIVA-SVT 100 study, just to highlight a few take-home messages and see what is the current evidence supporting the DOAC, especially for special groups of SVT patients. And then in the second part, we will discuss future studies, some ideas, and also some preliminary results from the DUST study. As Prof. Ageno has reported, I mean, these are the main results of the RIVA-SVT 100, but I would like just to point on two take-home messages. Now, the first is that this was the first interventional study which was evaluating the acute treatment of non-cirrhotic patients with splanchnic vein thrombosis. And the second message is that if we have a look at the incidence rate, I mean, this number, they might seem a bit higher compared to what we are used to seeing in patients with deep vein thrombosis of the lower limbs or pulmonary embolism. However, we should not forget that splanchnic vein thrombosis patients, they have an intrinsic higher risk of both bleeding event and SVT recurrence. If we have a look at the previous studies, well, the ideal study design would be a randomized control trial. However, if we have a look in the literature, there is only one randomized control trial on this topic, which was done in a few Egyptian centers and included patients with a liver cirrhosis associated with HCV. And in this study, 40 patients were randomized to Rivaroxaban 10 mg twice daily, and another 40 to warfarin with an INR range between 2 and 2.5. Despite the treatment, the dosage of treatment is lower compared to what we use in normal clinical practice. However, this study did not raise any major concern either with regards to the safety or the efficacy of the Rivaroxaban. There is also a guidance which supports the use of the DOAC for patients with splanchnic vein thrombosis from the Subcommittee of the Control of Anticoagulation of the International Society of Thrombosis and Hemostasis, and both Prof. Ageno and myself contributed to this guidance. Basically, we suggested the DOAC as a first-line treatment for patients with non-cirrhotic, non-malignant splanchnic vein thrombosis. In cancer patients, the DOAC might be considered as an alternative to low molecular weight heparin, except for some categories, patients in which low molecular weight heparin has been shown to be safer, such as those with luminal GI cancer or genitourinary cancer. And with regards to cirrhotic patients, they might be considered as an alternative to vitamin K antagonist after an initial treatment period with heparin after reaching clinical stability if they are not contraindicated by the severity of liver dysfunction. However, if we speak about splanchnic vein thrombosis patients, there are some particular categories of patients in which actually the DOACs are contraindicated. Now, it's not uncommon to see patients with hepatic dysfunction. However, we have to keep in mind that the DOACs are contraindicated if the child puke class is C. And for Rivaroxaban, there are also some data that it might accumulate in patients with a child puke class B. In addition, the DOACs are contraindicated in patients with severe renal insufficiency, creatinine clearance less than 15 milliliter per minute, even though nowadays there are also some data for apixaban in dialysis, but that's a particular subtopic. And the dabigatran is also contraindicated if the clearance is less than 30 milliliter per minute because it has a higher renal clearance. And finally, it's not uncommon to find patients with thrombocytopenia, but the DOACs are not recommended if the platelet count is less than 50 per 10 to the 9 platelet per liter. And then if you have a look at the yellow light on the traffic light, there are some categories in which we need to exert special caution or a case-by-case evaluation. For example, if we have a patient with a mesenteric vein thrombosis, one of the potential problems that might arise with the DOAC is the problem of malabsorption because they are given orally. If we have patients with gastroesophageal varices, well, gastroesophageal varices per se, they are not a contraindication to anticoagulant therapy as long as an adequate prophylaxis is performed. However, they are frequently associated with severe liver disease, so that's something that needs to be considered as well. A few years ago, we conducted a survey, a physician survey, in which we involved physicians from different thrombosis society, the ISTH, the Thrombosis Canada, and also the Italian Society for the study of thrombosis and hemostasis. We proposed some case scenario. For example, with regards to splanchnic vein thrombosis, we had a case of a woman with a portosplenomesenteric provoked thrombosis, and the case of a man with a cirrhotic portal vein thrombosis. And even though at that time the DOACs were not as commonly used as right now, we can see that they were still considered by a certain number of physicians, especially in the first case, in which it was a patient with a very low bleeding risk. So now the next part of my talk, what is the future of the treatment of splanchnic vein thrombosis? Well, if we think about the ideal study design would be a randomized controlled trial in which we enroll a population that it is well defined. So patients with splanchnic vein thrombosis, ideally all enroll at the same time, either a diagnosis or after a certain amount of month of treatment, in which as intervention, they all receive the same drug at the same dose. And ideally, there is a comparison with either a standard of treatment or maybe a comparison between DOACs. And as outcome, considering hard outcomes, major bleeding, recurrent thrombosis, mortality. However, real life is far away from the ideal study, because we should not forget that we are talking about a rare disease. So it is difficult to enroll a certain number of patients with splanchnic vein thrombosis. In order to reach the aim of the RIVA-SVT 100, it took us around 5 years to enroll 100 patients. In addition, the fact that the DOACs are officially, at least off-label, in most countries, creates also a number of problems with ethics committee, bureaucracy, paperwork. So it makes things more complicated. And finally, considering the outcome of interest, if we consider the hard outcomes, these are rare outcomes. If we have a look at the phase 3 registrative trials for Rivaroxaban, Apixaban, and the other drugs, they needed to enroll more than 1,000 patients in order to show superiority or non-inferiority between two treatments. Now, an alternative approach could be maybe to use composite outcomes or to use other surrogate outcomes, such as vessel recanalization. I was having a look into clinicaltrial.gov a couple of days ago. There are 2 randomized controlled trials on the topic that are registered. One is the report, which basically includes a population of patients with chronic portal vein thrombosis without high-risk thrombophilia. They were randomized to receive either Rivaroxaban 15 mg or no treatment, and the outcome was the incidence of any type of thromboembolic event, arterial, venous, or death. Now recruitment is completed. More than 100 patients were recruited, but there is the follow-up that is still ongoing. There is another small randomized control trial that has been registered. In this case, it has been registered by a center in India, and there are the inclusion criteria are cirrhotic patients diagnosed with portal vein thrombosis randomized to dabigatran or placebo. And the main outcome is recanalization of portal vein thrombosis. And for the study, recruitment is still ongoing. Together with Prof. Ageno and a group of friends and colleagues, we are conducting the DUST study. Now, DUST is an acronym, which I hope it will not influence the outcome of the study, but DUST stands for DOAC in unusual site venous thrombosis. Now, the aim of the DUST study is to evaluate the rationale for the use of the DOAC for the treatment of unusual site VTE. So not only splanchnic vein thrombosis, but also other sites of unusual venous thromboembolism are included, and also to assess the safety and effectiveness of this approach in real-life clinical practice. Now, the DUST is a multi-center observational study, prospective. We are including adult patients with an objectively diagnosed unusual site VTE, defined as not involving upper limb, lower limb, and pulmonary artery. treated with any of the DOACs. Now, the only exclusion criteria is patients enrolled in interventional studies evaluating the DOACs for the treatment of unusual VTE. We planned a minimum follow-up of 6 months from the beginning of the DOAC. There are no particular restrictions with regards to the timing in between the diagnosis of splanchnic vein thrombosis and the beginning of the DOAC, although we are accepting only diagnosis of the past 5 years. And the outcomes are major bleeding according to the IHTH definition, clinically relevant on major bleeding, venous and arterial thromboembolic events diagnosed according to the standard for each site of thrombosis, mortality, and if available, vessel recanalization. The study is ongoing. We hope to activate more centers in the near future. There is still a lot of paperwork that needs to be done, but we are close to the end. And we are expecting to conclude the enrollment by the end of this year, and thus to conclude the follow-up by the end of 2023. This is the current state up to a few days ago. There are 119 patients enrolled from 13 centers distributed in Italy, Malta, in the US, in France, Spain, Slovenia, and Israel. And among these, there are 69 with splanchnic vein thrombosis. And I'm going to give you a few data with regards to the 69 patients. As you can see, these are the baseline characteristics, actually very close to the one of the RIVA-SVT 100, so a mean age around 55, a prevalence of male sex. Most common site of thrombosis is the portal vein, and around 50% of the patient had more than one thrombosed vein. Of note, we have also one case of Budd-Chiari syndrome, but because in this study there was no exclusion criteria with regards to the site of thrombosis, being an observational registry. We have also a group of patients with an asymptomatic splanchnic vein thrombosis, around 20%, and that would be a nice group to analyze, of course, once the data collection is concluded. And with regards to risk factor, there was a group of patients with unprovoked SVT, then different infections, including also COVID-19, liver cirrhosis, recent abdominal surgery, solid cancer, hematological cancer, including myeloproliferative neoplasms, and hormonal estrogen hormonal treatment. In 10% of the patients, the DOACs were started immediately. In the others, there was a period of treatment with other anticoagulants, preferably parenteral anticoagulants, unfractionated, low molecular weight heparin or fondaparinux, and also a group of patients treated with VKA. Again, I want to stress that since it was a register, observational registry, there was no exclusion criteria. So also patients already treated with VKA could be included. If we have a look at the median duration of treatment, it looks like on average, they were started quite soon after the diagnosis, I would say within the first month. However, if we actually have a look at the interquartile range, it looks like there is probably a group of patients that has been treated after a certain number of months. And then again, once we will have the final data, it would be nice to perform a separate analysis for that group of patients. The most commonly DOAC that was used in this case was apixaban, followed by rivaroxaban. Now, as you can see, the dosages that were chosen, the treatment was left completely at the discretion of the attending physician. So you can see that the dosages that were chosen were quite heterogeneous. And however, what we can notice is that mainly the antitenase DOAC were chosen for the treatment of splanchnic vein thrombosis. And finally, one of the questions that was asked to the investigators was to express the rationale for choosing a DOAC in SVT patient. And the most common reason was the favorable safety profile of the drug, following by the oral route of administration and patient preference. Other things that were considered were the lack of need for blood monitoring. Some physicians pointed out their personal experience when treating patients with this condition, and also the expected higher patient adherence. So these are my conclusions up to date. So we have seen that the RIVA-SVT 100 showed that Rivaroxaban can be considered as a reasonable alternative to standard anticoagulant treatment for patients with non-cirrhotic SVT. However, I think we should consider this study as a starting point because more research is needed on the use of the DOAC in SVT. There are still a number of open questions. What is the optimal DOAC? What is the optimal dose? What is the optimal duration? And given the rarity of this condition, multi-center international collaborations are really fundamental. Preliminary data from the DAS study show that actually in real life clinical practice, the DOACs sometimes are used and they are used at different dosages and usually started after an initial lead-in treatment with heparin. And I would like to thank you for your attention.
Thank you, Dr. Riva. Thank you both. So I think we will move on to the questions. So we had a first question, or the only question actually, is from Dr. Roger, and he was asking to Walter specifically. Walter, you mentioned that a few times about recanalization rates and how important they were potentially as a surrogate outcome. And Mark was asking whether there was a proven correlation with clinical outcome and whether that was a valid surrogate outcome indeed.
Yeah, thank you. Hi, Mark. Thank you for the question. I think this is a great question because, of course, first of all, I think having a surrogate outcome that is reliable and is relevant is very important also for the planning of the future studies in this field. So there are data, of course, not too robust data, but there are data suggesting that the lack of recanalization is associated with increased risk of recurrence, but also, and even more probably, to an increased risk of bleeding. So for this reason, actually, if you discuss with hepatologists about the optimal duration of anticoagulation in patients with portal vein thrombosis, they will, in most cases, rely on the recanalization. So in other words, many of them, and even some of their guidance documents, suggest to stop treatment when recanalization is achieved, because this is considered a reliable endpoint to predict a low risk of recurrence. I could not find, to be honest, such a strong evidence to support their point of view. I believe that we may want to consider additional research to support this surrogate outcome, but again, I think this is a very important one. Which may be useful to design future studies, considering the possibility, of course, to have a limited number of patients to be enrolled.
Thanks. All right. So, well, feel free to type your question in the chat if there are more questions. Maybe to both of you, actually, about, we were, obviously, it has been very challenging, right, to do these cohort studies and at the end of the day, it's always a limitation about observational studies. And so how can we overcome that? Or how can we improve also the confidence in the results kind of thing, or the generalizability of the result when it comes from these observational?
I can start, and then I will leave of course, Nicoletta to also answer to this question. Well, I think this is a crucial question, and I think it also goes in the direction of the guidance document that we both presented from the ISDH. What is the evidence to support the indication for the DOAC, and what kind of data can be considered sufficiently reliable? Now, I think that if we do translate our level of confidence from other settings, starting from pulmonary embolism or lower limb DVT, we will never be confident for sure. However, we have we have used heparins and vitamin K antagonists with exactly the same quality of evidence. So unfortunately, in this setting, what we do and what we've been doing for many years is to translate what we learn from other settings, and then we have learned from our own experience. So what I'm saying is that this evidence is, of course, weak, but probably we will not have real solid evidence. And I think we are just trying to support the idea that for many patients, evidence from usual site thrombosis can be translated. And then we have to confirm our decisions with observational studies that may foster our clinical practice. I think this is the best we can do, unless we can really consider a worldwide study that may allow us to really answer in a more definite way the question. But again, it would be a very, very challenging process. So I think we need to slowly keep adding information with registries, with these studies, and do what we've done with previous drugs in this field.
Yeah, I fully agree with what Prof. Ageno was saying. I mean, the main problem that comes out from observational study is that there is an intrinsic selection bias. So, I mean, the patients that are enrolled, I mean, are those for the ones for whom the physician have chosen to treat them with the DOACs. So their level probably of comorbidities or other measurable and unmeasurable confounders, they might be different from the type of patient that is enrolled in a randomized control trial. However, unfortunately, given the rarity of the condition, it becomes extremely difficult to plan and to perform a randomized control trial. Also considering that, for example, for the RIVA-SVT 100, it took us around 5 years to enroll 100 patients. And the only suggestion that I can have are, I mean, as Prof was saying, trying to perform wide collaborations, and also at the same time trying to keep collecting data from observational study, maybe trying to keep some variables homogeneous, such as the time point at which the patients are enrolled, or trying to keep similar dose of the DOACs. Trying to find some criteria to reduce a bit the heterogeneity that there is in an observational study.
It's tricky, right? In the diagnostic world, for example, we can do these cohort studies, but at least the management studies, but we have anchors, and it's also likely easier to check for failure when, for example, when we assess the 3-month risk of recurrent VTE in a diagnostic study, right? In your case, it's harder because you just have to work with rate of recurrent VTE, rate of bleeding, and know what to compare that with. And I guess along the same line, Mark Roger was asking us, I think it's part of the same discussion about how do you then determine sample size in a study like that? Was it based on the expected VT recurrent rate and the confidence interval, or the major bleeding rate and so on, or was it a convenient sample size, or can you tell us more about that?
So this is another excellent question. So we tried to do exactly what Mark is referring to, and we are doing the same now that we are trying to plan a study on long-term secondary prevention with low-dose direct anticoagulants based on confidence intervals related to rates of bleeding in particular. Unfortunately, the number of patients that we would need is about 3 times higher than the number we enrolled in this study. So we started with this idea, and then we found out that we would have needed too many patients, and so the study would have been really unfeasible. And again, it took us 5 years to complete this one. So the choice was really for a complete sample of convenience. We decided to start with the first 100 patients to see how long time it would have taken us to get there, and to have more information on rates that could have been informative for us for the design of future studies. So based on current evidence, and Nicoletta can be more precise because she's done this work also recently, if I recall correctly, we would need, based on the available evidence, probably about 350, 400 patients if we want to make a more proper and formal sample size estimation. And unfortunately, unless we really, and of course, I would love to hear that we'd invent, to think that we'd invent another bodies we can aim to target this number of patients, but otherwise it's very difficult to start a study aiming to enroll 350, 400 patients. Nico, you can correct me, of course, but the numbers were about in this ballpark.
Yes, I mean, we were trying to do some sample size calculation based on previous studies that we did. There was an Italian collaboration of Splanchnic vein thrombosis patient treated with VKA after the initial period. So we were trying to estimate the risk of bleeding, but however, I mean, having some confidence interval within more or less in the same range, it would require more than 350 patients. And another limitation that I see here is also with regards to grants and funding. I mean, because most of the grant applications, they cover a period of around 2 years. And for a rare disease like it is Splanchnic vein thrombosis, a 2-year time frame for enrollment, unfortunately, is not enough to reach a reasonable sample size. So most of the time, it's actually a convenient sample size. I mean, we call it as a pilot. We try and we see what comes out.
All right. Yeah, makes sense. In the another question on the chat about APLA and whether you would suggest testing for APLA prior to either starting or switching to a DOAC in patient with SVT.
Yeah, Nico, do you want to take this one?
Okay, now I would personally test for antiphospholipid only, not actually as a requirement prior to switch to a DOACs, but only if actually I have the suspicion that that patient might have an antiphospholipid syndrome. So if it's a young patient without any other risk factor for thrombosis, unprovoked events, or particular situation, in that case, I would go for an antiphospholipid testing. And then, of course, based on the results, the DOAC might be contraindicated, because I mean, we all know that if there is a triple positivity, the DOACs are contraindicated. I wouldn't personally go for a thrombophilia screening just as a pre-DOAC test. I think that's not supported by evidence.
Okay. And then there was a last comment by Mark. I don't know if it requires an answer, but he was wondering whether the net clinical benefit, so doing major bleed and recurrence, and then could help designing an RCT with a reasonable sample size.
I think it's an excellent idea. And also don't forget the potential relevance of recanalization, that despite the fact that the evidence is not that robust, but it's considered to be extremely relevant by many colleagues, in particular hepatologists. So this is another way around that we may consider. But very happy to discuss this. I mean, personally, I'm very open to suggestions that the more we can do on this topic, the more our patients will benefit, because I think this is a very important area. And from this area, I think we also learn more about thrombosis in general, because this is a very unique model, I think. And we haven't discussed patients with liver cirrhosis, who represent a unique model on their own.
Mm-hmm. Yeah, for sure. Yeah, that's certainly a good point as well. All right. Anything else? Any last minute question in the chat? No, I can't see if anyone is typing or not. So I think, well, we are leads to the end. And so thank you again to both of you. That was these were really great presentation on a important, challenging topic. And highlighting again need for collaboration and wide academic international collaboration when it's a domain where pharmaceutical companies are very unlikely to intervene. So really that highlights what we can do together and do better together. So thank you again to both of you. Thank you to the attendees and to our sponsors who are here on this last slide. Have a good rest of your day, everyone.
Thank you. Bye.
Thank you.